I can share in Dan's absence if that's helpful. So I think, what's that?
Awesome, thank you. I'm gonna go on mute now.
Okay. I think we usually start with let's start with introductions actually. So I'm Malika, and I use she, her pronouns, and I'm a member of the committee, and I manage peer support services at HCRS. Let's do committee members and then DMH and then public.
Okay. I'm Kate, and I am a new member, as far as I understand.
Yeah.
Awesome. My name is Eva Dayan. I'm a member of DMH and here to support the committee. I'm technically on the quality team. I'm a quality management coordinator.
This is Tom Weigel. Sorry.
Oh, go ahead, Tom. No, go ahead.
Tom Weigel, the medical director at DMH.
And this is Jess Bernard. I am the assistant director of quality for DMH, and I use she, her pronouns.
And this is Trish Singer. I'm the director of adult services at the Department of Mental Health.
Okay, my name's Ward Nile. I'm a member of the public at this point, prospective member, should there have been a quorum here, and just an active person around the state and different advocacy things. So.
I'm Greg, and you've a member of the public, and you've heard pretty much all of my qualifications. If you have any questions, I'm happy to answer anything that you have.
I'm Lynn Cardozo, and I'm a prospective member of the committee. I am a person with lived experience, and I professionally am the director for the Vermont Communication Support Project. We provide communication support services as communication specialists to people with disabilities in court and at state administrative meetings. I was also the longtime executive director for the statewide Independent Living Council for a decade or so, and the executive coordinator for the Governor's Committee on Employment of People with Disabilities for a number of years.
Thank you so much. Is there anyone else on the call who didn't introduce themselves?
I just wanted to add that Hillary Melton is the one that recommended that I asked if I join the standing committee.
Yeah, thank you. And so glad to have Ward, Lynn, and Greg with us as prospective members. Really, really happy that you're here. And we'll definitely, I would like us to make time, make sure if you have questions, there's space for us to address those. And this is really unusual to not have a good number of committee members here. I don't know what's going on. Hopefully everyone's well. Okay, so reviewing the agenda really quickly. We need to look at the minutes. We can't vote on those, so maybe we'll defer that. Check in about membership, and then DMH update at 12:15. Maybe we can push some of those other things until after that. Eva, is there, do we have someone from DMH today? Or who is that?
We had someone planned and they got pulled into a meeting last minute. So I've asked Allison if she can start a little bit earlier with her piece. And she said yes. I'm just looking at the time on that.
I think she's joining us at 12:25.
Allison's joining at 12:25?
Yeah, unless you've heard else. Yeah.
Okay.
Yep, that looks accurate.
Okay, cool. And then hopefully we'll have someone else after that doing an update.
It looks like Allison's piece is going to be what we're going to hear from DMH this meeting.
Okay.
But that does include an update about some things that are going on, including some grant activity. And Tom is also on the line, so I'm sure he could provide if there's been anything remarkable and new going on. I don't want to put you on the spot, Tom, but I guess I'm putting you on the spot.
Sure, happy to do that.
Okay. And then we had for our business talking about the letter to DMH, which has been in process for a while, drafted by Vicki Warfield, who's a member of the committee on leave right now. We'd asked about any statutory updates. We need to talk about the listening session next steps and where we've gotten with that so far, and talking about membership. So we'll see what maybe we can, Kate, if you're good with that, sort of play this a little bit by ear, because there's a lot of variables this time around.
Absolutely.
Okay, cool. So maybe we can, if we're deferring the minutes, just talk about membership stuff really quick before Allison joins us.
Mm-hmm.
Eva, do we have any applications that have come through?
Yes, currently Ward's application is ready for you, and references have been checked for that, and I think Marla has that update, and that's the only standing application at this time.
Okay, great. And we haven't been sent that application yet, right?
Yes, it should be in your email as of Thursday of last week or Friday.
Okay, great. And are we able to have, between this meeting and the next, a vote over email about Ward's membership?
Jess, how do you feel about that?
For transparency to the public, votes really need to happen during meetings.
Okay, we can schedule that maybe for the beginning of next meeting so that Ward could participate in that meeting if voted on. Kate?
I have a general question. This is Kate. Is there a target in terms of how many members you are looking for on the committee, or the makeup? I mean, I know there's guidelines about the makeup, but I'm curious, are you in sort of a growth period at this point with the committee?
Yeah, I think, correct me if I'm wrong, Eva, or whoever else knows, but I believe it's supposed to be 9 to 15 people.
Oh, yeah,
so we, for a very long time, have not had even the minimum number that should be on the committee.
Wow. It seems like there's some real renewed interest in these last few months.
Yeah, I think so, yeah. Ward, Lynn, or Greg, does anyone have any, well, we don't have much time. Any questions, I guess, that you have about the committee or about membership process?
I do. I have a couple of questions. And you sent me a lot of attachments in the email, and one of them I saw that I would be interested in reading would be the bylaws, if that's possible, or does it have to wait till you become a member? And the thing is, what do I need to do for an application? I see that on some of the attachments. Malika, I'm addressing you, the attachments that you sent me. One of them has an appointment application. Is that the application that I would have to fill out?
I think so. Honestly, I don't know what I sent you. I think I just forwarded you something.
Yeah,
that
you
has some
sent me
attachments.
stuff that doesn't even open.
Hello? Does anybody
I
hear me?
We haven't. That's the first we've heard of you, Bert.
Yeah.
Okay, I'm sorry. I've been here for like 5 minutes. Eva just responded. I apologize. I had to reinstall Skype. I even tried to do another dry run last night, but I had to reinstall. I'm sorry. I'm sorry. I'm late. I'm probably not the best person to do minutes right now. I've been really struggling for months now. I want to be a part of the committee, but my concentration is not even existing really. So that's an exaggeration. Sorry. Is Eva doing minutes? I mean, Vicky's not here either.
Yeah, I think Eva's doing minutes.
Okay.
Glad you're able to join us. Better late than never. So
I mean,
glad
I
to
feel
hear.
capable of doing that if I were running at full steam, but that's just not the way my life is running right now. Sorry. I know how to do them. I feel capable of doing them. But it's probably better that I just. I mean, can we have someone else do that? I'm sorry. I feel unproductive.
Yeah, I think Eva's on it. No worries.
Okay, I'm sorry. I'll be quiet.
Have to do it for as long
now.
as you need.
Thank you.
Sorry you're having a hard time, Bert.
It's fine. It's to be expected anymore.
Yeah, I get that.
I want us to be. I want us to have the autonomy that we all want to see, and that we all want to have. And I feel like we've made important steps towards that. I feel like we have a significant amount of momentum that is hopefully going to be productive. But for me to spend like 12, 15 hours on our meeting minutes is probably not the best case scenario, especially because I had to email them 3 times. So
yeah, that's fine. It makes sense. We're fortunate to have Eva available to do that.
they're awesome. They really are. Thank you, Eva. Maybe sometime in the future here for me. I can be quiet, and we might as well continue.
Thanks, Bert.
Yeah.
Greg, I think I lost what your question was.
Who, me?
Yes.
I was just curious about the bylaws for the standing committee, and I didn't know if that was something that you got after you became a member. And then my other question was just about what application do I use to sign up? I have in some of the attachments that you sent me, one of them is appointment application for governor office for Ward, and then Ward's resume.
Yeah, I think I just forwarded you the email that has the link to this meeting so that you could join us over Skype. And maybe Eva, if you're willing, you could send to Greg and Lynn, if desired, all that info, the operational guidelines and the application and that kind of thing.
Absolutely.
That'd be great. Thank you so much.
I just need your email, Greg. Is it possible to either put that in the chat box or get an email from you?
Let's see. Let me see if I can see where the chat box is.
Greg, if you want, I can share your email with Eva. I think that he hung up by accident.
I think so. If you could share that, I would be happy to coordinate with him offline about all those
Sure.
things.
Sounds good. Cool. I think we're still waiting on Allison. So, Lynn, I don't know if you have any, or Ward, any questions.
Ward is muted.
No, I shouldn't be.
There you are.
No, I'm pretty good. I'm kind of committed here. I'm just waiting for you to vote on me.
Which actually now I think we're able to do that now that we have 3 people, correct?
You do have quorum now, yes.
If you vote, then I'll get really noisy because then I can speak.
I'm sorry, guys, but I somehow shut myself off of Skype. I won't do that again. Last thing I heard was Malika was going to give my email so I could get the documents.
Yeah, exactly.
Okay, cool. Thank you.
Yeah,
Sorry
no problem. Would Kate and Bert, do you want to, should we have a vote quickly on wards and membership before we move on, or do we want to hold that off when we have more time?
I feel like we should go into executive session, right? Is that not an appropriate procedure? I mean, are you the only member of the public here today, Ward?
No.
No,
I'm from the public as well, Bert.
Greg, right? Yeah, I should have known.
Sorry.
I mean, I'm not an expert here. I'm kind of new to Robert's rules and all. That's a little bit of an exaggeration, but isn't it appropriate that we go into an executive session just for a minute to vote? I mean,
I don't know for sure either, but I think we could probably opt out of that if we wanted to.
that works fine for me if both Greg and Ward are comfortable, especially Ward with that. I mean, if we're voting here,
I've got no problem.
Kate?
Kate too, right? Sorry, Kate.
Okay. Great. So someone how do we do this here? Do we need a motion? Or can I just call a vote?
You can call a vote if you want to. Do you want to have any discussion about Ward's application, or I have the email from Marla about his reference checks if you'd like to hear that.
Maybe Ward, if you want to, I don't know, if you want to just say a couple quick words about your interest and your relevant experience briefly.
Sure. I'm a person with lived experience and was basically just living my life, watching Netflix and stuff like that. And then a man in Burlington got shot and killed by police. That was Bill Grennan. And that kind of got me out of the basement and active in all this. And since then, so I did a lot of advocacy with the Burlington Police Department. And then from there, got involved in some of the work in emergency departments that were going on. And that was Act 82 a while back, and a lot of work relative to what are alternates for people rather than going to the emergency department. And then kind of from there, I moved on to, children's issues and got on the Children's Standing Committee. And where else? Bunch of other stuff too. So I've got a pretty broad involvement in what's been going on around the state. So I just got attracted to the Adult Standing Committee because you are starting to really gel together and starting to get some momentum on things. So it seems like a good place to be right now.
Thank you so much. Kate and Bert, any questions or any additional information that you all want or need to see before we do a vote?
So I just have a question. So Ward, I'm understanding that you are currently and continuing as a member of the Children's Committee as well.
Yeah, for now. I mean, my term, I'll basically be at 3 years at the end of this year. So whether I continue on with that, we'll see. I mean, I haven't even talked to, you're hearing more than anyone else has heard almost, but other than my wife. But we'll see. I mean, if it's been good to be on that committee to get the perspective from the youth perspective. So.
Yep. Thanks.
Might I ask about your involvement with NAMI? board.
Oh, right. Yeah.
Not sure if you put that forth, but I'm aware of that, so I feel a little bit rude in bringing that up. But
No, sorry. I'm also a board member for NAMI Vermont.
Okay.
I've been that since a little over 3 years, I guess now. Yeah, because when I got involved with advocating at the Burlington Police Department, I kind of got support from Lori Emerson there to kind of get going in with that. But I quickly got connected with Wilda White and Ann Donahue and folks like that on that work. But yeah, I'm a member there. I guess a voice of people with lived experience on their board.
Awesome.
So.
Yeah, me too. I was just curious. It would be if I were being cynical, or overthinking maybe the Mad Pride movement. I think that the NAMI staff is great. I think that they do awesome work. It's a little bit more medical model, which ironically has been sometimes helpful for me. I feel like somehow the balance between pathways where everyone is a peer and acknowledging that there is a science of psychiatry is probably the happy medium. But and like I said, I feel a little bit rude asking because you didn't bring up your experience on the board there.
Yeah, I guess it's yeah, it's an interesting involvement for me because it's a place to do advocacy. In a sense, I am a voice to their board from our perspective, and also it's Lori's pretty good about listening and understanding what's going on. And I agree with you. There is a pathologizing perspective on NAMI that we don't really like so much.
Well, I feel like if we could somehow utilize it's ironically labeled as a nationwide grassroots organization. I feel like if we can utilize those widespread connections to advocate for some degree of peer support, I think we probably.
Yeah, definitely. I mean, I kind of understated a lot of things I do. I was really involved in getting peer voice involved with the what was a redesign of the Central Vermont Medical Center Hospital and Emergency Department. So I was pretty active in getting a lot of voices there.
Okay.
Fortunately or unfortunately, I'm not really sure which, that effort kind of got stopped due to
with COVID
cost overruns. Well, no, it was actually stopped before coronavirus, and
okay.
But it was a good experience because I know Ann Donahue and Dan Towell and I were pretty active in all that last summer and fall, and we learned a whole lot. And from that, we went on to do advocacy at Northwestern Medical Center, who we did an emergency department, and also University of Vermont Medical Center. So we did reviews of that, and we also have been pretty involved with the Southern Vermont Medical Center.
Okay.
And these are interfacing with Green Mountain Care Board and writing public comment.
Okay.
Yeah.
Thanks, Ward. I appreciate you being patient with my inquiry.
No, it's good.
I see your face around. I have respect for you for sure. So
I hate to ramble. I hate to divulge that. I mean, I could go and say, well, I was voted advocate.
No, it's all good. And I was going to continue the conversation by asking about St. Albans and some of the VPS stuff going on up there. But anyway, thank you.
Yeah.
Yeah, thanks. Do Kate and Bert, do you all feel ready for a vote now, or?
Surely.
Yes, I do.
Okay. So the vote is on whether to add Ward, or recommend to the governor, I think actually technically is what we're doing, to add Ward as a committee member.
Correct.
So all in favor?
Aye.
Aye.
Aye. So I think that passes it unanimously, because that's everyone.
Thank you.
So Ward, I believe the way that we've been doing this is, the governor tends to take a while. So people such as Kate are, functionally at full committee members,
Right.
until that official word comes through, which we expect will be the case.
I'm more than familiar with the length of time it took for me to be approved. It was probably over a year.
Wow.
And it was so long that DMH very kindly changed the rules for people who could get reimbursed for meetings like this to allow for that length of time. So, yeah.
Awesome.
Great.
Cool. So we have Allison here, and I think we should move forward with giving Allison the time to do what she came here to do. And Lynn, if you have questions, we'll also make time for those during this meeting. You're here, right, Allison?
She
Hello?
is. She may be having trouble unmuting.
Her picture shows here, so I don't know.
She shows that she's unmuted, but we're not hearing her.
Maybe Tom could give us any updates while we're waiting.
Sure, I'd be happy to give some updates. I actually have to hop off in a little bit for another meeting. I guess these are just some DMH and general mental health updates, I think, since we last met, and they are in no particular order. Let's see, one is that there seems to be a lot more access and use of telehealth. According to the Medicaid people, the DIVA, there were about 1,500 telehealth claims in February and over 40,000 in May. So really a huge jump in telehealth, and that I think a majority of those claims are actually for mental health. So a lot more services being provided that way. Certainly a focus on suicide prevention, given kind of the dual or maybe triple actions of coronavirus, the worries about infection, the social isolation, and also the economic impact. So we're certainly making efforts in that realm, and I think Allison is heading that up with another group. There have been no upticks in suicide from kind of a year-wide tally. The 5-year average of suicides to date would be about 46, and in 2020 we've had 37. So it's not an increase in numbers, but it's something we're keeping an eye on. We are seeing an increased use of the Vermont Crisis text line, and websites related to this use have gone up. Use has gone up on that. So certainly something we're monitoring and trying to proactively work against, I guess, on the suicide front. I think last week the second payment went out to the designated agencies to continue to support them, to keep them afloat, so that they will be there as needed now and in the future. And I think there will be another wave of funding after this, where an application process will be required. So people will apply for funding based on the financial needs, and then that will be reviewed. Springfield Hospital, I think last time we mentioned that the Wyndham Center is going to be stood up as a COVID positive unit, as an inpatient unit. The contracts have been signed. The construction work has started on the Wyndham Center to bring that up to safety standards, and they've been very helpful and collaborative in this process. That unit should be ready to accept people starting in July, I believe, and that's a 10-bed facility. And again, it would be for people who are COVID positive. So the idea is that somebody either waiting in an emergency department who needs an inpatient bed who's COVID positive, or somebody who contracts COVID at another facility could be transferred to this facility to cohort them to avoid kind of the nursing home situation where everybody, patients and staff, get infected. There's been school-based mental health concerns. You know, with schools closed, some schools are reducing contracts for school-based mental health services, but obviously the needs during the pandemic would likely only increase. And so DMH is working with the Agency of Education to provide guidance to schools and school systems on maintaining services and reaching out to children and families. With the Brattleboro retreat, we're working with them on ongoing sustainability and planning. With COVID-19, there's been a big strain on them, both from a kind of a capacity and utilization standpoint, but also on the staffing front, and they've had some financial issues. And so I think that today they were DMH was presenting to the Joint Fiscal Committee at the legislature an action plan to have the retreat modify some of what they're doing so that ideally they'll be kind of financially viable in the future, and also be there to serve the needs of Vermonters. They have over 50% of the inpatient mental health capacity in the state, and they have 100% of the child mental health inpatient capacity in the state. So working with them on that plan and hoping to get that across the finish line this week. The Middlesex facility, it's a little complicated. I know that you've had updates that the residents at Middlesex were moved to VPCH temporarily due to staffing issues that allowed them to more fully utilize kind of the combined staffing of VPCH and Middlesex. And in the interim, the youth who were at Woodside through DCF were moved into Middlesex because we had been looking at Woodside as that COVID positive unit. And when they were there, I guess the youth did damage to the Middlesex facility. And there's also some water quality issues there that we need to have fixed before the residents can move back to Middlesex. And then on that same note, we're working with various groups on ongoing design work for a potential future secure recovery residence that would replace Middlesex, because Middlesex was really set up as a temporary facility after Irene, and it's really past its lifespan from that perspective. We've had input from advocates and community partners, and we've had input from some of the folks who run other residential units in the state. And I know we have a meeting today. I don't know who's giving input today, but I know that a meeting in the near future will include residents, current residents of Middlesex, to get their input on the design and such for that. I think that's it for the big topics at DMH. I'm happy to answer a question about any of those things as best I can, or other topics if you have questions.
What was the water quality issue that you're talking about?
I don't have the details right in front of me. So apparently, I think the building and grounds had a couple of tests in the past that revealed slightly elevated uranium levels, and I think that they were above the Vermont state threshold, but below the federal threshold. And I don't think DMH was made aware of that. And so we're following up on that. I believe there was retesting of that. And it's on it's a facility on a private well, which I guess is not very typical for a state facility like that. And so the plan right now is to install a new water purification system prior to moving residents back there. And I believe that DMH has had meetings with advocates and Vermont Legal Aid to discuss the testing and the plan. And I think that's about the extent of the details that I have for that. The levels of, I guess the levels detected, we've been working with the Vermont Department of Health, and they said that you would have to be exposed to those levels on a daily basis for like 70 years for it to be any sort of medical concern. And it was, again, it was kind of in this line between the Vermont threshold and the federal threshold on that. So they were not concerned about that, but obviously it's also, you know, a touchy subject. So,
yeah.
This is Kate. I have a question. This is Kate. I have a question for you.
You bet.
Could you go back to the, after you were speaking about Middlesex, you were talking about a future recovery treatment center. Did I understand that correctly?
Right. So essentially, Middlesex was built as a temporary secure residence, and we are looking to get funding for a replacement for that. That would be as many as 16 beds, and the possible site would be the current Woodside location. So the Woodside would be torn down, and a new facility would be built there. And so we're working on design plans for that, or if it's located somewhere else, then design plans for that. So.
Okay. And are you still conducting public input meetings regarding that?
We are, yes. Yes.
Could you include this standing committee, notify us of any of those that are happening? I don't believe we've gotten any communication about those.
Sure, I'll make sure to send out. Or we have a meeting today, so I'll bring it up today at that and make sure that everybody's included.
Perfect. Thank you.
Eva, do you want to just jump in, since this group had been involved, and just kind of talk about what kind of transpired?
Yeah, the last time the meeting invite was shared and Vicki had planned to go, but the meeting time conflicted with last month's meeting of the State Program Standing Committee, and so that's kind of where we're at. Is we reached out to that group to say, can you please try to plan future public input, not during this meeting time, but we haven't heard back since then. And sorry, it wasn't Vicki, it was a member that is no longer a member of the committee, and so she has stepped away. But the goal is certainly to include this group again. It would be helpful to know when meetings happen. And so thank you, Dr. Tom. I would appreciate going back to that group and making that appeal again, that the second Monday of the month from 12 to 3 is a bad time, because we'd really like to include this group.
Yes, I will. I'll bring that up again today. So I actually have to hop off to get on to that meeting now, if there's no more questions.
I assume, since you didn't mention anything, there's no changes to the protocols or testing with on inpatient units with patients and staff?
No, we are. I don't know if it was released yet, but we've been working on a notification that people need to be tested before they're admitted to inpatient psychiatry units or residential treatment facilities to, again, try to reduce the risk of infection in these congregate living sites. But right now, I don't believe there's any sort of plan for testing within those facilities unless there's concerns about a particular case.
I guess I'd just like to say really quick, since sounds like things are moving ahead as they have been for a while, but I would love to see DMH not investing in expansion of any inpatient units right now, and instead focusing money and energy into respite and community support.
And adequate testing as well, Malika. That goes without saying that even as much as a contact tracing has been difficult, it's irresponsible for any individual to say, I'm not going to get tested because I'm already COVID free and so it's not anything to worry about. You know, we need to engage in the face mask, the social distancing, the things that are preventing this plague from spreading. So sorry if I'm a little bit passionate, but that to me is an easy answer that goes without saying. So
yeah, I think I agree with that. I think that right now the policy is that if any patient or staff member tested positive at any particular facility, all of the patients and all of the staff would be tested immediately. It's a similar model to what they did in the Department of Corrections. If there was an inmate or staff member positive, they tested the entire facility immediately. So, and then what you do is you try to separate or cohort the people who are positive so that they don't get other people who are negative infected, and then you continue to kind of test and retest until everybody's COVID free. So I think right now the Department of Corrections is COVID free in this moment in time, and they're continuing to monitor that. So, and then with regard to the community resources and funding versus inpatient, I think DMH has that as part of the 10-year plan, and in part there's this combination of needing to build up and invest more in the community resources so that we can in the future invest less on the inpatient side of things. So, but it's harder to take money away from inpatient immediately and put it into the community resources if it's going to take some time to build that up. But that is part of the 10-year plan.
And I think the counterpoint to that is, building up the inpatient unit is going to, we're not going to, I don't think, building up the inpatient units while also very slowly building up community supports is going to be effective in the long term in transitioning towards more community support and less reliance on inpatient. If we want to rely less on inpatient, let's just do that. And I don't think we're going to do what we need to do in the community until we have to. That's what it seems like to me. So.
Yeah, I think during COVID, we're trying to do a couple of things to maybe take advantage of this situation to maybe make some changes for the better. One is that a lot of the emergency services have been taking place rather than at hospitals and in ERs, actually by telehealth, which means that we're reaching people, in their homes or with their supports and with their families. And I think on some levels we're able to, avert some hospitalizations that way. I think when people end up physically in an emergency department, in my mind, they're a little more likely to actually end up in a hospital bed after that. So I think that's one thing we're trying to focus on and expand. And in addition, we're working with DCF. Currently about, I think, 1,800 to 2,000 people are housed in hotels and motels. Some of them were homeless, or some just had unstable housing, maybe sleeping on somebody's couch, a friend or a family member. And so we're working with DCF to try to have more permanent housing options as people transition out of hotels and motels. There's research to suggest that when you house people and provide them with stable housing, that they utilize both medical and psychiatric services less. That's both outpatient and inpatient. So people have fewer medical and psychiatric hospitalizations when they have more stable housing. So at least right now, those are two things we're actively working on during COVID.
This is Kate. I just have one comment. It's really a comment. It seems to me that it's sort of in these COVID times, it's got to be awfully difficult for both community-based services and inpatient services to do some of those therapeutic support kinds of things, running groups, for instance, that, regardless of the agency, that those are awfully difficult to run when you're, it's so impossible to get people together when you need to maintain such distance, and yet those kinds of groups can be so therapeutic. So it's a pretty tough thing to manage.
It's a really tough time, especially for face-to-face groups. I do know, I think as I had said earlier with the telehealth, they're allowing billing for telehealth groups, and even I believe I think we were able to get an exception for people who were able to just call in. So some people don't have the internet bandwidth to do video, and I think that we were able to make an exception and allows people to even just telephone into some of those meetings. So I think in Vermont that moving forward even past COVID, having groups that people can participate in via telehealth is going to be really important and helpful. We've got a somewhat rural state. It's hard for people to drive, an hour to go and attend a group and then drive an hour back and worry about parking and things like that. So I think we might be able to actually provide better mental health services to some people, especially people who might have had trouble physically accessing services before COVID.
Tom, this is Ward, and I also go to the Program Quality Committee at UVMMC, which they report out on what's going on in SHEP 3 and SHEP 6, and at least in April, and it seemed like in May, they were actually reporting that people didn't have like iPads or devices to be even able to attend group meetings on the floor. They were short resources, and so people weren't able to participate that were inpatient, which is kind of shocking. I think they're trying to address that, and they may have made some progress, but as of like the middle of May, they hadn't, and they may have now. But it's concerning that a large organization like that can't provide resources for inpatients to participate in, group sessions or even, meeting with family member over it. So I'm concerned, and I don't know if it's on the agenda. I think we may be going to talk about it later. I know you were leaving, but I wanted to put the thought in there that if it's happening at UVM, it could be happening at other inpatient facilities where people don't have technology to do telehealth that we think is so great.
Yes, this is something, in fact, that we asked about last meeting and didn't get an answer. And I also emailed Trish last week or so asking if there was any update about that. And I think she was still waiting to hear back from BPS or something. So, I'd love to hear an update about that as well.
Trish, are you on the line? Were there any updates about that?
I was on the line. I talked briefly with Topher last week. He's been out with some personal stuff. Vermont Psychiatric Survivors has a relationship with the hospital that have involuntary admissions. And according to Topher, and he's going to follow this up with an email, the issues aren't around the availability of devices so much as they are around some of the policies that are in place for folks who are admitted on an involuntary status and their privileges about using those devices. And so he's been working with the retreat and Rutland Regional Medical Center on having better access, more frequent access to those devices. But he said it isn't actually the availability of the devices so much as policies around their use. He says he hasn't had any conversations with that VPS, Vermont Psychiatric Care Hospital, has not reached out and said that they've had any issues with needing devices either, but I did urge him to contact Vermont Psychiatric Care Hospital as well. So I expect an email. I told him that the Adult Standing Committee had a question about this, and so as soon as I get it, I will forward it on to Eva so she can send it all out to you.
And Tom, what has been done or what will be done to address this issue with to ensure that everyone, regardless of voluntary, involuntary status, or what hospital they're in, what unit they're in, is going to be able to have access to the technology to communicate with advocates and supports privately and whenever they need to?
Trish, do you have an answer on that, or is this something, I can certainly bring it back to the leadership team.
I do think it's a good question. I'm not sure who's going to the designated hospital meetings. I think that to go beyond the involuntary folks, it's a broader question than VPS can answer, and I think it is a good question.
Yeah, and I don't think it makes sense for VPS to answer the question. I think it makes sense for DMH to answer the question of what is going to be done to ensure that people in the designated hospital system have this, what seems like should be a very basic right, and we're months into a pandemic. So it's concerning to me that hasn't already been attended to, given that this committee has brought it up before. And Tom, I'd love for you to speak to that as the medical director.
Sure, I can bring it up with the leadership team. And this is not, I can bring it up with the leadership team again and see where things are at.
So, Malika, as you know, we have a relationship with all of the hospitals, but we don't necessarily have contractual relationships with all of them. So I think this is something that it's a good conversation to have with them at the designated hospital meeting. And I think I just don't go to those meetings, so I don't know what's been said at those meetings. But I think it's a good point to bring up.
Yeah, and I think, I understand y'all don't work at those hospitals, don't have direct necessarily control over everything that they do, but I could have done more about this, frankly, at this point than what I've heard from y'all about, like, even having any conversations. So I understand that, and also feels like it's really necessary to hold some accountability around this issue. And I think I don't know whose role that is at DMH, and maybe those people whose role it is aren't here, but would really like the DMH to be responsible for attending to this.
We can talk among ourselves and figure out who will take lead on this and get back to the same.
Thank you so much.
Thanks, Trish.
So I've got to hop off the call, but thank you for having me, and it was a pleasure talking with everyone and hearing from everybody. Bye-bye.
Thank you.
Thanks, Tom. Nice to meet you.
You too. Bye-bye.
So Allison is on the line. We're we're also overdue for our break. How do you want to proceed with that, committee members?
I'll defer to the majority.
Ward, do you have an opinion?
I'm on back. I'm unmuted. I'm good. We can keep going.
Yeah, I'm good to keep going too. I'd be more in favor of skipping a break this time and ending early, personally, if that works for others.
Fine by me.
That sounds good.
Yeah.
Cool.
Awesome.
Allison,
Do
if
we
you
still
have, sorry, Jess, I just want to make sure I don't have the agenda in front of me. Do we still have room for public comment?
Sure, that's an important part of what we do.
What do you mean, Eva?
This is Jess.
Jess, are you referring
Usually the break coincides with public comment, and because public comment.
The comment for this meeting is usually at the very end, so there should still be time before they head out.
Thank you. Like I said, I apologize I didn't have the agenda in front of me, so sorry about that. Thank you very much.
Thanks for making sure that we do it. It's important.
Okay.
Allison, yeah.
All right. Well, given that we are a little bit short on time, I just want to check in with everybody to make sure that I'm covering what you're interested in today and that we have time to talk about all the things that you're interested in, which I had offered to come and do an overview of payment reform, given that a lot of the questions and things that this group was interested in kind of sit within this larger context of payment reform. So it's going to give just a brief overview of what that is and what stage we're at in it at AMH and AHS. And then I also understood you wanted some more detailed information about suicide prevention. So I have some information about that as well. Does that sound like what you've signed up for? Okay. Mm-hmm. I have the ability to share my screen, and if you're up for it, I might do that so you can take a look at some of the images which kind of help us understand payment reform. Does that work?
That's great. Thank you.
Okay.
Great. All right. Thank you so much.
And could people who are not speaking mute themselves?
You as well. Thanks. All righty. Bye.
Okay. Can people see this?
Yeah. Mental health payment reform.
Perfect. Okay.
Might I ask, Allison, is that from one of the documents that you sent through Eva, maybe, from the website?
So what I did was I took a couple things from each of those, because those documents that I sent, there's a lot of information in there. It was too much to go over in 20 minutes. So everything in here is from that, but this isn't the total amount. This is a sample of what I sent you.
Okay.
Does that make sense?
Yes.
Okay. Out of curiosity, could I get a yay or a nay for those who have had an overview of payment reform before?
Yay.
Nay.
No.
Nay.
Yes.
Nay.
Okay, that's helpful. Thanks. So if you are interested in this for more information, on the Department of Mental Health website, it's under initiative. And the very first thing it talks about is why we did this thing. And so one of the reasons this is coming up is I know there's new members on the Adult Standing Committee. Mm-hmm. And so around 2017 was when a lot of this work was done to start preparing for payment reform. And I, for one, wasn't even at the state at that time. So for me, I had a lot of catching up to do as well. But the idea was for years, both providers and individuals served were saying this whole system is built off getting paid to spend time with people. And
there's all these eligibility issues and I can't get what I need until things are really bad. There's just so many problems, and it created this really fragmented, inefficient system. And people often it was put on the person trying to be served, whether or not they knew which door to go into. And then that was just what it was like on the ground. Even when you went up into DMH, say just our department alone, forget the other departments, inside our department, we were siloed as well, with like someone's in charge of this program, someone's in charge of that program, and there was different funding buckets for each one. And there was different rules for each one. And so it was just inefficient and provided some barriers to care. And so around 2017, we decided that you can't fix everything today, but that a huge first step would be to fix how the money flows so that there's less barriers and less eligibility documentation stuff that people have to go through to get served. And so what it did was it took all these payment structures and they bundled them into one monthly case rate payment, where beforehand, some of them were in a case rate, some of them were fee for service, some of them were you could access it, but you had to call DMH first and send us all this documentation, and then we would decide if the person would be put on a waiver. So there was just a lot of many pieces where all of that was taken into one bucket and bundled into a case rate. So I'm going to explain what that means and what a case rate is as well. And the idea was this was to move away from does the client fit program eligibility. So CRT is a great example. If a client needed case management, so say they call, they want services, they start by seeing an outpatient therapist. The outpatient therapist is working with them and they say, you know what, this person really feels like it could be helpful to have someone help them coordinate their care with their primary care physician. They're finding, that their voice isn't heard in that environment and they feel really supported by me, but I can't go with them to those appointments because I'm an outpatient therapist and I don't get paid for that. You can't bill for that. And so it used to be, well, you have to qualify for CRT to get that service. And so it used to be, well, you would go that route and then someone would say, oh, you haven't had a mental health illness for long enough, or you haven't been hospitalized. And those could be barriers to you getting case management. So what payment reform did is we say, if you serve that individual for whatever level of service they need for that month, here's your money for the month. If they need case management 4 times a week, 1 week, and once the next week, go for it. You do not have to be eligible for CRT to get that service. However, you need to make sure that if someone is eligible for CRT, they have prioritization of services, which just means that, yes, you can serve people in a more comprehensive way, but we have to make sure that this doesn't take away from the capacity to serve those who are most severe and persistently in need of help due to acute mental health concerns. So we're walking a line and we're trying to watch both sides of it all the time. But it did offer this bundled payment and sort of said, we trust you, give them what they need. And what we did with that was we also took, I'm going to show you a picture, 3 manuals. So we took the CRT manual, the fee-for-service manual, and then this manual was for kids who EFT was a children's manual, and we put them all together to say, let's come up with some of similar rules so that it doesn't so from an individual's point of view, if you're served by outpatient, you shouldn't have to learn a whole new set of things if you're served by someone else. And can we come up with some common guidelines for what is quality care? And so what this did was twofold. I'm first going to show you the billing stuff and I wouldn't have put this in here normally in this kind of talk, but because of COVID-19, it's actually become really, really important. And so the big change that this has done is we're doing something called prospective payments. And so we go ahead and pay the designated agencies ahead of time. So here's your prospective payment. You get the same amount every month, and this is based on the amount of people that you've served historically. And we've taken a 3-year average, and we say we expect that you'll see about this many people. And if you serve this many people, you've earned your case rate for the month. And whether they needed 3 outpatient appointments or a really hefty array of services, we trust that you will give them what you need, what they need. And we're going to, most importantly, fund you regularly with money that you can count on that won't waver from month to month, because we've heard that lack of being able to count on funding can really impact agencies' ability to provide flexible services. And we moved to this system, it would have been in 2018 now? Yeah, gosh. And it was because of this that we were able to provide financial security during COVID. We were one of the first of the departments to move into payment reform, and there are many departments who are sort of working on it but aren't there yet. They're still fee-for-service. And in a fee-for-service environment, when COVID hit, there was, as you might imagine, a huge drop in services. Some had, maybe 2 or 3 weeks where just overall service need was not able to be given. Others moved to telehealth very quickly. But as you might imagine, if you got hours of service, say you went to a day treatment program, you're not going to do that on Zoom for 6 hours. So a lot of our programming has dropped about anywhere from 50%, and then it's starting to creep back up again. So if we hadn't have moved to payment reform, there would have been a huge loss in revenue for these agencies. It was because we had this prospective payment model that we could say, we think we can hold you in this. We had to make some adjustments. And I'll show you what that adjustment means. So here was the deal for the money. It was, if you keep serving, we took your last 3 years, and we didn't actually set it at 100%. We said if you see 90% of what you've seen over the past 3 years, and you've hit your target, and you make all your money for the year. And then what we did also was we tacked on the sprinkle, which we show at the top of this graph. It's this little light green spot, and that's your value-based payment. You get a dark green child payment, a light green adult payment, and then our outlier payment. And then we sprinkle on the value-based payment. And so at the end of the year, we look back and we say, were you able to hit it? Good. You're all set. If people weren't able to hit it, then we have to look back and either adjust our caseload moving forward, which is likely what we were planning on doing, or recoup money if there was a major underserving in any organization. I'm going to pause there for a second. I just want to make sure that people understand the difference between what was the fee-for-service model prior to this and what world we're living in now. Okay. All right, so what does this mean? I'll tell you what our goals were for it, and then some of the bonuses that came out of it in terms of what we've heard people want, but also there's still issues and problems to deal with. But one of the first things we were able to do was there was a lot of archaic rules kicking around that once we put all 3 manuals together, we were able to say, all right, who wins on this rule? Like, some programs made it a rule, other programs didn't, and we pulled together, and some things were able to be lifted, like place of service limitations. It used to be that there was a lot of services that you couldn't do in certain places. And the reason for that was if you served someone, the perfect example that I always think of, if there is a person who is served ongoing by a provider that they trust, they at one point in their treatment need to access inpatient services. That provider that they know could not bill for any contact with that person while they were inpatient. So if visiting them, calling them to coordinate their discharge, attending treatment plan meetings, all of that could not be billed because it was considered something called concurrent billing, because in fee-for-service world is all about the time and the date. So at that time and that date, that person was being served an inpatient. Therefore, no other provider could bill for that time and that date for another service for that person. And those were fee-for-service rules. Because we're no longer in fee-for-service, we can say, yes, absolutely. If you're providing case management, service coordination for a person, regardless of where they're at, it counts, and it counts towards your caseload. And you can earn your caseload for doing that work. That also means if they're served at another DA. So if someone's accessing a crisis bed at another DA, their case manager or outpatient therapy from another DA can still see them, have a treatment episode of some kind, and bill for that, because it's no longer a big deal if it's same date or time. We've gotten rid of those rules. The other thing we had to do is decide, what does it mean for someone to count for the month? And so we had to create sort of a standard minimum of, according to quality treatment, what would be a minimum amount of service that we would say, yes, you served that person for the month. So for example, a 5-minute phone call, no. But for some people, it may be that they're working towards discharge and they do a 15-minute check-in with their therapist or case manager, and they might even get down to a 15-minute check-in a month. And so we were able to look at that sort of array of services and what typically happens, and set minimum thresholds to qualify. And so for some people, if all you had was a 15-minute check-in, as long as it was part of your treatment plan and that was what you had agreed to and it was appropriate, then it counts. And all of the money for that person is drawn down for the month. And the goal there is, we know that that also makes up for people who need a lot of service in a month. And we want the agencies and the providers and the individuals themselves to help make that decision. Where it used to be, for CRT, for example, if you needed to see someone a certain amount of hours in a month to keep them at that level of funding. And so if for some reason they didn't need to be seen 10 hours in a week, you were pushed by your program manager to see them 10 hours in a week, because if not, you could lose their funding. So prior to this, there was these eligibility and a lot of sort of bureaucratic rules that weren't set just to meet people where they were at. And this kicked open those doors for that flexibility. So what do we need to worry about when we move into a payment model like this? And one of them is, how can we be sure that providers and individuals have the tools they need to determine how much someone needs to be seen? Because in the old world, we were a gatekeeper for certain services. Or if a kid that was served needed a waiver, they had to go through the AMH. We now say, we trust you, you do it. But we did understand that we really needed to bolster the assessment process and make sure everyone had the tools they need, and that also there was some similarity in the tools. Because I was not aware of this back in my days as a provider. Although when I looked around and talked to my friends, I kind of had this idea, but it became really clear when you get to the state level, a lot of providers do things in a lot of different ways. And you can get, for example, when I was reviewing just the clinicians at my agency when I worked at NCSS, we found that providers had favorite diagnoses. If you were someone who was really well trained in trauma, it was really easy to see trauma, and you would get a lot more PTSD diagnoses from certain clinicians than you would from others. Some are really well trained in substance use and can spot that very well, where others, it's not something that's necessarily on the forefront. Not to mention, just in the system itself and people who have been traumatized, it's hard to talk about, and the skill of people asking them those questions varies across the state. And so we felt like for us to be able as a system to say, just give people what they need, we needed to make sure that they had a tool that could help them have that conversation, and that there was some standardization in how those conversations were happening. And so we made a push to make sure that not only were assessments happening with a standardized tool, but that reassessments were happening. And so we weren't just sticking with what we first learned at the assessment. So for children and youth, the CANS was the chosen tool that replaced the child behavior checklist as the tool for standardized assessment in children. And this information, as you can see, was from March of last year. Since then, the adult tool has been chosen as the adult needs and strengths assessment, which mirrors the CANS. That's why those were put in. It was for that reason to say, hey, do we think that there's a comprehensive assessment happening, and how do we know, and what tools does each agency have to oversee that? We also streamlined the treatment plan. So in each of those 3 manuals I showed you before, they each had different rules about what treatment plans had to do. So we took those 3 different manuals and came up with common goals, objectives, and then what needed to be included, who, what, when in the crisis plan. This was the first time that collaboration and integration was written in a mental health manual that we've put together. It's something that we've always promoted but hadn't really written down. And so it also had to do with that billing issue, where prior to this we struggled to say, please coordinate care, when every minute spent doing that couldn't be billed. So now that it can, we started putting together some guidance for that, and it's something we're looking to expand upon in the coming years with help from providers and persons served to make sure we're all working in a good direction on this. But it is a first step and something that we're looking to do more of as releases allow and as people are interested. And then the last piece that I'll go over is just the third leg to the stool here, which is, it's one thing to give prospective payments. It's another to say, please do assessments where you can, that come with some data so that you can look and make sure that people are getting the right level of care. But at the end of the day, the whole exercise only works if we have some outcomes to determine if people are better off, and that this exercise has increased the quality and value of the programs provided. And so starting in 2017, there were groups put together to do that work. And the very first thing they realized they needed to do was figure out how we can even do the same thing in the first place. And we started with reporting services. So I don't know if this group knows about the MSR, but it's the monthly service reporting. And it's the information that the DAs and SSA send us about what services happen. And it's the information we've used for decades to explain things, and it's not good enough. What it is, though, it's just how much. So it's how much happens, how much case management happens, how much service coordination happens. Even though we consider that the bare minimum, we realized it doesn't come in a standardized way. There was a lot of problems with the data. And if we couldn't even figure out how to do the basics well, we knew that moving forward, reporting on other things were going to be tricky. So we started with just let's see if we can get this one thing right, how much, and worked on standardization. And so this year is the first time where we had set a target for it. So all that means is people have always been supposed to submit this data, but now if you don't submit it in a timely and complete way, you could lose funding. So that's what the value-based payment piece was. It was to set some goals that had some teeth to them. Very limited funding, it's 1%, and actually this year due to COVID, we didn't move forward with that. We did not have a financial withhold this year because we didn't want to withhold money from the agencies during a pandemic. But in normal times, it would have been what people were working towards to earn that money. And the full gamut of what we're doing, this is kids and youth, but I'm going to show you the adults, is where we're headed. And so this is basically our vision for how value-based payment will work in payment reform and the buckets that things fall into in terms of the measures for adults that we've looked at. And so in this first column for process measure, all of these are happening this year. We're capturing the percentage of clients who are offered a face-to-face contact within 5 days of calling and saying, I need help. We're then documenting percentage of clients seen face-to-face within 14 calendar days of their first assessment, because we know sometimes you can get in right away, but then the next visit takes a really long time. Applying 3 screening measures to help with bolstering some standardization to make sure people are actually asking these questions and asking them in an evidence-based way. A set of consumer satisfaction surveys that we have targets set for which percentage of clients who indicate that services were right for them, that they got the services they needed, they were treated with respect, and that services made a difference. And then for the outcome measure, we've actually had a long debate about this, and I will out myself as somebody who came in with a critical lens on this too. When we were looking at tools, the first idea was to find a tool and say, well, let's pay people if people do better on this tool. If the individual they serve improves based on this tool, then you get money. And that's kind of, it makes sense when you think about paying for value-based payment. But research shows, and just intuition would tell you, that's a tricky incentive to give, especially depending on who gets to score it. And it also just ignores the human experience at times, as if suggesting that the only reason someone's circumstance might change is because of the therapeutic relationship, when something might have happened in their own life. Very good reasons for somebody decompensating or going through grief, or a million things. So the thought was we were putting this on hold, and we were saying, you know what, I think what we really need to make sure of is, going back to the conversation about assessment, are there tools that can help make sure that we're doing really good assessment and we're matching people's treatment goals to what they need. So this current measure is on hold, and we're looking to use the ANSA, but without tying the outcome of the ANSA to funding, just using it to provide transparent assessment and tying it to treatment goals. So that was the shortest I think I could ever explain payment reform. But this is the value-based payment piece, and then the rest is really a, process improvement. We try it, we go back, we talk with our partners, we talk with stakeholders, we see how it's going, we adjust, we keep going. Thoughts, questions?
I just have a quick question. This is Greg. I happen to know on one of the slides you showed, I think it was about the children, you had something that said EFT. And I'm not sure what that meant, but I was wondering if that meant emotional freedom technique.
It doesn't mean emotional
Okay.
freedom technique, although I'm intrigued now to learn what that is.
What, emotional freedom technique?
Yeah.
Oh, it's one of the things my group that I run, I've been running now for almost 5 years. I started doing it and then it turned into a pop group, through VPS. And one of the groups that I taught was about the emotional freedom technique. It's a tapping that you do. It's like an acupressure for when you're having an emotional issue that's doing a lot of having a lot of having a lot of problems with it. And it's a different type of tapping, and you say a little thing. It's quick and.
Greg, I'm sorry to interrupt. I just want to remind you that this isn't public comment period.
Yeah.
And maybe you could hold that more about that until then.
Absolutely. Sorry.
Sorry, and I asked. So sorry, Greg.
It's all right.
Jess, do you want to help me out with because EFT ended as I started, and I'm afraid I'm going to get the acronym wrong if I try to say it.
As far as I'm aware, enhanced family treatment is what we typically, use it for.
Okay.
Yep. So we now call enhanced family treatment IHCBS, intensive home and community-based services.
Okay.
And it's something that children and youth are eligible for, but we no longer hold the keys to that level of service. The agencies are able to make those decisions on their own. Other questions?
I have a question. This is Kate. This is all, if I'm understanding correctly, there's a sort of what this requires is a treatment plan for every individual who is served. And if that's true, my question is, who is responsible for creating that treatment plan that then details what services they should be getting and funded?
Yes. So it's the backbone of all services, and no individual can move forward without a treatment plan that is signed by them. We have a lot written in our manual about how to do treatment plans and how to do them in a person-centered way. So it should be a collaborative effort between the person served, their provider, and anyone the person would like to be involved in their treatment planning.
Is there a person who is in charge of that? So I guess what I'm wondering is if an individual is seeing, say, a psychiatrist, a therapist, those are different people. Is there a designated person who is standardly in charge of that treatment plan if they don't have a case manager, for instance?
So there's a lead service coordinator for every person. And so if you have one provider, then they default as your lead service coordinator. But if you have multiple, someone needs to be identified. And it depends on each agency, but usually it's someone who does the case management. But if there's not someone who does the case management, it could be the psychiatrist, it could be the outpatient clinician. But and you'll read it if you read the mental health provider manual, there's a section to say there needs to be someone identified as the lead service coordinator. They get the signatures. They're the ones who are notified that a new one is due and by which date. They're in charge of facilitating the process.
Thank you.
So, although I didn't read all the way through the severity of psychiatric illness tool, I feel like ANSA is a step in the right direction considering that. But in reading through ANSA, I took a whole bunch of notes, which I don't have in front of me. It seems to be, very, very kind of, I guess you could say medical model, and certainly not very collaborative. I feel like the payment reform seems to be great work for me in streamlining how the DAs document their services and such. How do you feel about the idea, maybe as Kate may have suggested, in streamlining something like a treatment plan with some sort of macro or basic format, which allows for this collaborative sort of network approach to assessing goals and progress. Because I feel like if if healthcare is a human right, and it most certainly is, then there should be an inherent level of accountability, both as a client and as a provider. So essentially, I'm expressing gratitude for this work because it seems to be very much a step in the right direction. I'd imagine as a case manager that helping someone to write a whole treatment plan in the space of a half an hour or an hour may be quite a challenge. But so I feel like somewhere between ANSA and the need, which I think, considering billing and funding, there should be a need, depending upon the level of care, to acknowledge the work towards being in better health through utilizing these services. Has DMH streamlined writing a treatment plan in a way that is a collaborative sort of approach? Seems to be that's what you were going to be working this year, but COVID came up as a roadblock.
Yeah, and so I think what strikes me is when I hear people say that they're not sure the ANSA is collaborative, because one of the ways we've worked on doing treatment plans in a streamlined, collaborative way is through the CANs. Okay. And the CANs came first. That was the kids version. And we have someone, the reason why we chose these tools at all is because they come from this group who has devoted their lives to coming up with collaborative assessment and outcome tools. And that's the name of their group, Transformational Collaborative Outcomes Management. And they don't support anything that norms people. And so what we've used to have in the past was things like a GAF or the ACEBA tools. Those are the checklists where, have you had this behavior in the last 2 weeks? Therefore, you must have ADHD or oppositional. It helps diagnose, and it puts people in a normal or not normal range. And what we found was those standardized tools are not normed on representative population. They promote systemic racism. Heaven forbid you have a developmental disability or you're on the spectrum. None of those behavioral norms apply to you. And certainly it just provides incredible judgment on interpreting someone's behavior based on a self-report of someone else asking, what have you done in the last 2 weeks? And so they took that. It was being anti-norming that started this whole process with things like a CANS and an ANSA. And so there's no total score. There's no us using the ANSA to say this person deserves to get this and this person doesn't. It's just you do the clinical interview, and at the end, it's basically a catch that just catches what were their needs and strengths, and at what level do we think that they put them at. And it is not for the provider to define. It's for the individual. It's their narrative. It's just sort of qualitatively coded by the person listening who's trained in the CANS and ANSA, but then it's shown to the person to say, this is what I think you said. Is this right, or do we need to make any adjustments? And then what that does is it identifies strengths that the person or whoever else we might be able to talk to in the assessment. So if some people aren't great at identifying their own strengths, sometimes you've got to dig with their family and their friends to have that admitted. So you take that information and it's coded. And what that does is then you have a transparent thing that not only the provider and the individual can see, but the provider supervisor, who then can go in and say, hey, this person has 3 strengths that I don't see you using in the treatment plan. Where's that at? And how are we doing? Where a lot of times, because things are buried in a narrative, they don't get lifted up. So by putting it in a data form, we can see it now. And we can also see it on a state level to say, geez, we used to think that our biggest issue was this, but turns out we found this with kids. 66% of kids identified not having the community connection. They couldn't say that they thought someone in their own community cared about them. That was information that was probably buried in a narrative for decades. But because we asked that question and it's coded on the cans, we now see it. So it's not someone else's idea of you. It's reflecting back your entire interview with the person and giving someone a chance to say yep or no, you didn't hear that right. Our goal is to use that information for better treatment planning and not just, well, we didn't have this as providers. I always do this. And we do 3 hours of case management, every week for a year, and then it's like rinse, repeat. And this gives a chance to say, does it really match what the person said their needs were, and does it attend to their strengths at all?
I think one thing that's to sort of build off of what Bert said about the medical modelness of the ANSA is that I understand that's the context we're working in, and hopefully we're working together to try to shift that. And so, it makes sense that a tool would be somewhat aligned with that. But I think I think the way that tools like the ANSA, certainly not in any way alone in this, but it sort of reifies these categories of the DSM, which doesn't seem to me to be in line with identifying necessarily areas of need. And I feel like it would be great if only we could modify it the way that we want to make it fit more within our values. And so that's, for me, really the challenge that I run into with the ANSA, is that we don't have the ability to make the tweaks that we would want to make to the extent that I think is necessary for it to both be usable in like how large it is, just sort of paring that down, and also shifting some of the language or the focus so that it's less about pathology.
I would like to read, if it's okay with the standing committee, the ratings from 0 to 4 in ANSA, or 0 to 3, which is 4 separate ratings. I can do so if the committee is willing to hear that after your question is answered, Malika. But
yeah, mine wasn't really a question so much as just a comment.
Okay. Can I read the ratings real quick? Because to me, it's very clear that these ratings are much more in line with something similar to a black robe effect than having a collaborative network approach whereby a treatment plan is built and co-created with the person receiving services. Would it be helpful for me to just to read these 4 categories? Because I think the answer is obvious when you read these, that maybe it's different for cans because youth can be harder to reach, but I think very, very simply that when care is a choice and an incentive-based suggestion, then the outcome will pretty much always be much more successful than when it's an identified need that requires monitoring per se.
Yeah, by all means, Bert, are you talking about the no evidence, watchful waiting, need to be addressed, or intensive need to be addressed?
You seem to be well aware of those categories, yeah.
Yeah,
I don't think that's really fundamentally any different from a black robe effect, which is the colloquial term for forced treatment. So.
No, I find that really interesting, and it's a good perspective for me to hear. I don't hear that as the provider being the one to decide that, it's the person. So that there's no evidence, It's something that we agree we're going to watch, but I'm not sure that I need to do anything about this yet. A good example of that is the substance use. It might be a person saying, you know, during COVID, I'm drinking more than I like. I think I've got it under control. I don't think I need a referral right now. It's not going to be on my treatment plan. We're going to watch it. 2 is, and maybe it has to do with our intake language, because we say, you know, what brings you here today? And when we think about it, it's what do you need in order to feel supported? And so a 2 means I need to do something about this. This is something that can't wait, can't go on next year's treatment plan. It needs to go on this year's. And then a 3 is it's not just a need, it takes priority. It's something that if we don't do something about right away, safety could be in jeopardy. That's not, and it's really, again, because I feel like Malika's done a good job of this as well. Being read by different people from different perspectives who have different experiences, the words can sound very different. And so I am really interested about you likening that to the black robe effect.
But surely it's often not what you say, it's how you say it. So in that sense, if there's a conversation that is collaborative and you know, it is had with mind to encourage and incentivize treatment options that may be seen as beneficial to the individual, then sure, answer starts to become a little bit surely perhaps even an effective tool. But you know, I think if we're using the questions that Anson puts forth and maybe using a different rating, then I think the effectiveness of Anson might be improved, and sounds might end up appearing to be or in function being more of a collaborative approach. But so yeah, it's not necessarily what you say, it's how you say it. I think minimally the ratings could be changed to have language which is you know, more kind and sensitive and in tune with a positive reassurance rather than a specific defined outcome or need. But anyway.
No, I mean, that is why I'm here, is to hear that point. And I think it hadn't occurred to me before that. I'm sorry, let me just let my dog out of the room before you won't be able to hear me over her. I think we've been around the block on this, and we go to, it's a national movement. And so one thing I'm learning is finding the right words that feel comfortable to lots of different people is a really tricky business. And so I think if you ask one group, it's absolutely never use that word. But if you ask another, it's, of course you would use that word. And so I think we don't stop trying. But I think I've also heard that this was saying it's a need feels like this is what I'm coming to you for, as opposed to saying it's a problem. So I think they've had these conversations, but I think it sounds like it's not in fitting with Vermont's culture and our attempt to move away from a medical model, which I hear Malika on. And when we first did this 3 years ago, we were really proud that we chose something. There's 5 domains in the ANSA, and only one of them is diagnosis, and that was like a really big deal. That it was so limited, but I think you cut to 3 years later, and it still feels not good enough. And we need diagnosis right now. It hasn't gone away in CMS and Medicaid, and we're responsible for that, and I can't draw down money without it. So that's a reality that I sit with and that we all sit with, but it doesn't mean that it shouldn't be railed against all the time, which isn't a great answer, but I think to Bert's point, there is some flexibility with this, and we can build reports that spit out our own language. So it's definitely something DMH is willing to consider, how to make this something that doesn't feel harmful, because there are times when I'm hearing that it may feel that way.
Yeah, thank you so much for that. Allison. I hear you on like we have to like sort of navigate this system where diagnosis is required, and I think the way that we do that can make a huge difference on how impacted people are by that current reality. And I think this is one, maybe small, maybe big way that we do that. And yeah, so if there's the way that we collect data, what data we collect, the way that we think about treatment planning, all really goes into how we relate to this necessary diagnosis, and whether that's something that holds a lot of power and credence, or whether it's something that we hold pretty loosely together with a lot of other voices. And so I think my recommendation or my hope would be that DMH would consider maybe doing something like the ANSA, but holding off on actually implementing that, and instead doing something that we are able to mold to be more in alignment with, I think, the direction that we want to head. So that would be my hope. And yes, the ANSA is definitely not the worst of all the possibilities, for sure. But I feel like there's we can get even closer.
No, I appreciate that, Malika. And I will say there is a reason we have some confines here, in that one of the things that it's really hard to do to move a system forward if you have no benchmark for comparison. I'm sorry, there's a parade of cars going by right now. So, but we will be hard pressed to move forward without something that has some standardization. Because at the end of the day, then we go to the legislature and we say, and this is why this is doing so well, and we think these programs are really impactful, and they say, oh, you made up this measure yourself. So it loses science, and that's a real reality. And so we've worked to try to find at least a community nationally who shares good values and seem to be closer in line with where we're trying to go. And I'm not saying we can't be leaders, and we're the first. So we're the first to tweak the ANSA. And so far, we've won most battles we've put towards them. And I think we can keep doing that. Where if you were to do that, try to do that to an ACEBA tool or something else where you want to change the words, it's impossible. So I have hope that it can be molded. And I think we need to try to take it as far as we can go.
Excuse me for 1 minute. Sorry. Can you tell me what the ANSA means? What you're talking about?
It's an adult needs and strengths assessment.
Adult means and strengths?
Yep. And it's it's called a collaborative assessment tool that is used to capture information from a clinical interview. Okay. So when somebody goes in and it tells their story, it captures that story in some data points that just says, when you talked about your symptoms of depression, do we think that landed on something that needs to be addressed on your treatment plan, or something that we don't see any evidence of that needing to be addressed right now? And okay. It captures it in either 0, 1, 2, or 3, so that at the end, the provider has something to show that the individual, here's where we landed in terms of helping us prioritize your story and where we want to go.
All right, thank you.
But Malika, I can update that we are going to pick back up the ANSA development team meeting. And so maybe that would be a good place to start in the next conversation is, how far do we think we can push this? And what's the best way to move forward without causing harm? And do we need to sit down and have a meeting with the creators of the tool to find out things like, can we change the names of the scores? How much tweaking can we do to language and still be able to use this to compare nationally?
Yeah, I think that that's a good idea. To yeah, really see how far we could yeah, push it and get the edits made that we would really want. Yeah, if I mean, yeah, I'm okay with that.
Okay, great. I have no idea how we're doing on time. I have stuff for suicide prevention. I can save it until next time. Totally up to you all and your agenda.
I think that waiting till next time, if that's possible for you, would be nice. I think I may be wrong, but I feel like maybe it was Marla who's had brought that up, and she's not here. So, is anyone opposed to that idea?
Of doing what? I didn't quite hear.
Having the conversation about suicide prevention next time or at a near future meeting rather than today.
Yeah, that's fine. That's fine by me.
Yeah, that's fine by me, Monica.
That's fine for me as well.
I have no problem.
Okay, cool. Well, thank you so much, Allison. Appreciate you being here.
Absolutely. Happy to come back. Thanks, everybody.
That was really helpful. Thanks.
Yeah.
Thank you, Allison.
Yeah, thank you, Allison.
Yeah.
And congratulations, Ward, on your new committee standing.
Thanks, Allison.
It's exciting to have
I
you
heard the parade go by myself, too. I heard that.
Yes, Ward and I are neighbors. All right, bye, everybody.
Bye-bye.
All right. Is that it for the day?
Not quite. I think there's a couple other things. One, we need to have public comment, and we didn't get a chance to hear from Lynn earlier. And then we had some different business topics we were going to talk about, and we already sort of talked about, oh no, we didn't really talk about any of these things. There's a couple updates I would hope for additionally from DMH, and we could check in about the listening session plans, and maybe if people are okay with it, we can defer the rest of it until we have a fuller group here.
Yeah, I see that in the agenda.
Okay, not hearing any objection. Could I maybe update folks on the listening session stuff, and then we can go to public comment?
Sure.
Sounds like a plan to me. Thank you.
Yeah.
Okay, cool. So I've talked a bit with Dan. Dan was working on, well, okay, let me back up. We started thinking a lot about the logistics and sorry, just got distracted by an email. It's sort of going to be a challenge to do exactly what we want to do, which is hear from patients on units, recent past patients during COVID, family members, advocates, and hospital staff. And so Dan and I had a conversation in which we thought about maybe instead of trying to have a shared call with all those different people, we focus on having video conferencing calls with folks on units, and those who want to opt into that, of course, and to do a survey with family members and staff. So that's sort of what we're thinking now. Dan's drafting up a survey, and I think it would involve reaching out to and maybe DMH can help with this, contacts at each of the hospitals to set up sort of like a time and space where there could be a call going on in a room, and patients could opt in or out of participating in that like town hall / listening session type of thing. Thoughts about that from committee members?
I think the tighter that you can get something like that, the better it would be.
Are we expecting to be able to serve people on inpatient units as well as the caretakers and such? Do you think we'll have a large number of people present at this event? Hopefully yes and yes, but.
Yeah, I don't know. It's really hard for me to predict. I imagine there would be some people who would be interested and some who wouldn't. I wouldn't expect no one. I wouldn't expect like majority of people on a unit.
I'm trying to envision this. Are you picturing in this listening session? How are, for instance, inpatient folks accessing that?
Yeah, so it would have to be. My understanding is that many units, if not all, now have like some. Probably not all, but some have like a room that's set up with Zoom or something like that. And it actually could just be over the phone. It doesn't have to be necessarily with video, but sort of a space in which people could go and sort of participate in a call together in a room, but that's not like out on the unit open to everyone.
I'm wondering is that feasible in an inpatient setting to have people participate in a room given COVID requirements? I think it'd be great to do. I'm trying to picture the logistics of it.
I haven't heard anything so far in having asked for this info. I think that they aren't doing that. My understanding is the units have lower numbers, but on the units they're more or less still interacting the way that they normally do. But maybe that's incorrect.
Yeah.
I think, Malika, this is Ward. At one point, like, I know more about UVM Medical Center than other places, but they did go into kind of a lockdown and people were restricted. But like you're saying, they're starting to come out of that now, and so I think the people might have the option of being in their own room if that's how they want to access via a Zoom or something like that, or be in a common room. I think at least UVM has a group room that's kind of set up for video calls like this. So, they're well positioned for you, I think, right now.
Great.
Okay, that's helpful to know. And my understanding is that units still are not allowing people to have like their own phones and things. So like there's maybe a unit phone or two, but that it would be hard for many people to call in from their room.
Yeah, I think that's something that we have to talk about, right?
Yeah, that's one of the concerns.
Right, that's certainly a concern. But I mean, as a minimum, people could participate audio. That's not ideal, but if that's what they wanted.
Yeah. I think it's a great idea, though.
Yeah, I think
good to know.
I think you have. I think you're courageous in doing this, and you know that you're gonna learn a lot on the first time you do it. You just have to accept it. You're going into the unknown and roll with it. You're a professional.
Yeah, and the draft of a survey, which we'll share with everyone, obviously. We'll also we're thinking be a bit of a template for the conversations, listening sessions. So we'll have like an idea of sort of a rundown of questions we want to explore if possible. And, just generally give people space to share whatever they feel is relevant. So there'll be some planned structure to that as well, a loose structure at least. And one other decision that needs to be made is like doing these sessions with different units on different hospitals. Is it a different one for each hospital with all units combined? Is it a one for just for any unit, any hospital in the state? Is it a different one for each unit? So that's a decision that needs to be made.
I feel like that's a very valid point, especially depending upon how much outreach and sort of PR we do for this event. Is it possible to put out a feeler and get an idea of what sort of interest there might be?
Yeah, Bert, to have an idea of numbers. If it's only one person per unit, then like let's do it all together. But so I guess we'd have to communicate. We'd have to have a point person for each hospital at least to ask about that kind of thing. So maybe we could. Who at DMH, Eva, do you think might be able to help us with that?
I'm sorry, with identifying like who to contact?
Yeah.
My best guess would be Norm McCart. I will send an email out to him and ask if he is the right person.
Okay, great. Cool. So Dan and I are working out some of the logistics of this, and of course everything will, any sort of final say will come through the committee if we're doing it on behalf of the committee. Is there anyone else, Kate, or Ward, who wants to be involved in the nitty-gritty process of making it happen, or would you rather just be sort of final say?
I'd certainly be interested in helping, although only, if you need the help, that'd be great. I'd certainly love to pitch in, but if, sometimes too many cooks spoil the broth. So if, you're looking for help, yes, I can help.
Awesome.
I'm interested.
Cool. Same here, Malika. If there's something I can do to assist, as needed. Yeah. I have a lot going on in my personal life right now, which makes things pretty challenging. So.
Yeah. Okay.
And cool. Yeah, and certainly reach out to me if I can help.
Awesome. That's great. Thank you all so much.
Like, for example, if you want help calling around to do a feeler about maybe what sort of numbers we might get or something like that.
Right.
Right.
Okay. Cool. Thank you all very much. Exciting.
That's great. I'm glad you're making good headway on it. Good.
Yeah, it's slower than I'd hoped, of course, but that's how things tend to go.
Well, you're doing an awesome job, Malika. Thank you.
I know I'm just a new person here or anything, but if there's some little thing that needs to be taken care of that you could put on my shoulders, I'd be more than happy to help out. I mean, I do a lot of stuff like this with I still run my group, but I run it from a safe house, and I use a phone, and we do conference call and stuff like that. So I've got a lot of experience with getting contacts made and stuff like that with the way things are now with COVID. So.
Mm-hmm.
Okay, cool. Thank you. So I think what else we have left is public comment, and at least I have a couple of follow-up questions for DMH. Is there anything else we need to be thinking about to include before we end?
This is Eva. If it's possible to vote on May minutes and discuss any changes you want to make, that would be great.
Oh, yes, right. Thank you. We can do that now. Yeah, let's also do that before we end.
All right, thank you. Let me, I should finish that process. Let me get my pencil real quick. Thank you, Eva.
While you're getting that ready, Bert, should we have?
I'm good. It was just on my table real quick. So whenever we want to go ahead. Again, I'm grateful for everyone's patience with me. I don't want to assume, but.
Could we maybe do public comment now?
Sure.
If there is any. So, anyone who's not a member of the committee or DMH, this is just a spot for you to share anything that you want the committee or DMH to hear or ask questions or whatever.
Well, this is Greg. Since I'm not a member yet, I'd like to become a member. I think this would be a very good thing for me to be involved in, especially with some of the experiences I have. Not only do I do my regular groups, and I started peer support up at the emergency room in the hospital here at SPMC. I've become a volunteer there so that I can do that. I also do a CAT TV show. CAT TV is our public access down here. So I have a lot of different experiences in different parts of, communication and stuff like that. So I don't know. I could be used in a million different ways. If somebody has anything they would like me to do, or, and I could get after starting to fill out the application and stuff like that. So this would be my first time here with you guys. I think it's been very eye-opening and stuff like that. So, I'm willing to do what I can at this point in time.
Greg, this is Ward. I was curious. Did you say you're doing stuff with Southern Vermont Medical Center?
Yeah, I have when Wilda first took over, they SVMC put in what they call the emergency care area, where they have 3 beds away from the emergency room. And if you're there for mental health reasons, you can go. Once you're medically cleared, you can go into this area, and you can do different things there. And one time I was having a crisis, and I went, and they told me about, I was going to be going into there, and I didn't know it was finished. And when I went in there, it was just like this stark prison. And I ended up writing a letter, an article about it, and it hit the front page of Counterpoint, and DMH got involved and found out that Thomas D., the president and CEO of SVMC, lied, and there was a whole can of worms that got open. And at that point in time, I offered my services to go in to be a peer person, to sit with people if they were going to be going to Brad, or different things if they needed someone to talk to, with lived experience and stuff like that. So at that time, I was able to put this whole thing together. So, they call me when they need me or stuff like that. And, sometimes I can be available to go up there and sit with people, or, be there and kind of give someone new that doesn't know what Brattleboro is like, or go away and, give them a better idea on what's going on and stuff. So that's one of the things that I've been able to. So somewhere along the line, I think it was it's about 4 years ago now that I got that together, and was on the front page of, like I said, Counterpoint. And then I did a follow-up after they had fixed and they had done a lot of the recommendations, and I actually, told them about, at that time, Brett had just gotten an award for what they had done to fix up for the patients. And I brought that up, and they had taken some of those ideas and implemented them in this ECA and stuff. So, and then like I said, now I do a thing on TV with my groups where it's about mental health, and I've included substance use as well, since that's a mental health challenge. So.
Thanks, Greg.
You're welcome. So, like I said, I'm here willing to do what I can at this point. If there isn't anything, then there isn't anything. But like I said, I'm willing and able.
Thank you. Is there any other public comment? Lynn, did you want to speak?
I have a couple of things when my turn comes around.
I think it can be your turn.
Okay. So firstly, well, thank you all for letting us all be guests again. And this is my third meeting sitting in, and it had been my intention to have my application in by now, but COVID kind of all took us on a little time management detour. So I've actually been quite busy since March, and but it is my intention to fill out my application and hopefully join you all as a bona fide member, if that's what you choose. I want to make a suggestion as someone who's sat in as a public person 3 times, and it happened last time actually, where when there's a guest who's participating, it would be great to be able to ask that person. Like today, I would have had a question for the doctor. But once they're gone, they're gone. So that might just be something to think about. But my question for the doctor would have been, how is the safety elements of COVID-19 being handled, mostly with regard to people who are experiencing inpatient care? And we already have heard the answer through conversation a few times, which is, in certainly some settings, nothing is being done as far as distancing, physical distancing. And in other places, there may be some efforts, but my concern with regard specific to mental health, and I would say I have the same concern with regard to people who have cognitive disabilities or intellectual disabilities, is that there is some sort of stigma-like assumption that these people, who in this case might happen to have psychiatric disabilities or disorders, are not able to be handled and managed in the same kind of a safe way as the rest of us. And whether that's true in some settings is perhaps another question, but an assumption that because somebody lives with mental health issues or a psychiatric disability or a developmental disability or an intellectual disability, that they don't have the ability, or better yet, we as the people who are responsible for people's safety don't have enough sort of creative know-how to figure out how to accommodate, is concerning to me. And there's sort of often in facilities, there's kind of like a herd mentality. I mean, everybody's safe or nobody's safe. And and I'm not saying, that is a universal statement per se, but I think it's something that I haven't heard come up in discussion as much as I think it should. What I have heard come up is, oh, those people have mental health issues. Those people are in the hospital for psychiatric reasons, and there's no way that we could figure out a way to keep them physically distanced. And because they have these challenges. So that was sort of a long ramble for what I would have asked the doctor to offer perspective on, because I think it's really important, and I can certainly say that one of my own personal passions in life and missions in life is to battle the stigmas and to make sure that people who have disabilities that may not be as easy to see as others, or may not be a matter of some kind of AT equipment to assist people with mental health circumstances, be accepted as people who need, the same kind of accommodations as anybody else. And so, as a certified communications specialist, I often say, oh yeah, we're like the ramp to communication. So I think it's really important as we look at this pandemic to sort of get up on elevation and say, have we done everything and provided as many accommodations to people with disabilities, whether they're mental health or not, that need to be kept safe? And look at that. So that would have been my question for the doctor. The only other thing that I have to say is that I look forward to this conversation that has been slated a couple of times for discussion on suicide. So although the numbers on suicide are not showing anything terribly rash during COVID, still the numbers that we've been given, and I think the doctor actually gave a number of 20, I don't know, Eva, do you think that's a fiscal year or a calendar year number that was given? For 2020 was 37. Would that have been calendar or fiscal?
That's a great question. I have no idea.
Because if it's calendar, then it's a little bit of a scary number, and if it's fiscal, it's a little less scary of a number. But anyway, I look forward to the conversation on suicide. It's something that I have another sort of particular interest in, suicide prevention. I have some ideas with regard to the message that is continually put out there to try and address people who are considering suicide, and I think there's a lot. I think there are some strategies that could be considered that could make a big difference. That's the communication specialist in me coming out again. So, anyways, those are my thoughts.
I have a question about that, Lynn. This is Kate. And I guess it's maybe also a question for the committee is, number one, I kind of want to point up, I think, one of your suggestions, which was when there's someone speaking at the meeting before they leave, to make sure and offer a chance for public comment, which I think is great. I think that's good. The other thing is I'm wondering, for me, it's always helpful to get things as much in advance of a meeting that I can look over before the meeting. Is it acceptable for someone who is not yet a member of the committee or who is coming on as a member of the public to submit things for the committee to read in advance of what they might want to present at the meeting? And if so, I'd be interested in that, in what you were referencing related to suicide prevention.
I think that's a great suggestion. I don't see why that wouldn't be possible, right, Eva?
Absolutely. I think the important thing is that we like to, if we can, send things to members that want them in physical copy before the meeting occurs. And so it's helpful to have them about a week before the meeting. So the Monday the week before, if I can get things digitally, then I can get them out physically before the meeting happens.
Okay. And
I could just respond to Kate, since you're referring to my comments, that I haven't put anything in writing with regard to these thoughts, and I can tell you if the committee it takes about 30 seconds for me to say what my thought is. But although I have done and do an awful lot of writing, I haven't put anything in writing with regard to this. But what I will say is that the message that I see for suicide prevention and have seen for years is, there's help. There's help, and I think that's somewhere in that message. And I have had this discussion with any number of people along the way, and doctors and psychiatrists, and it's not something that isn't used, but it's not a message that goes out there. And I think that the suicide prevention community might want to think about some sort of a campaign that really says wait, because when somebody is suicidal, the concept of it will get better and that there's help is generally not something that is really being processed at that time. All of the suggestions, I think, about staying with people and being patient and being calm and all that, it's all, I think that's all, great and valid. And the message that there's help is valid. But for somebody that is suicidal, I think that what can be tangible is this concept of wait. If that's all that they need to hold on to, is like, all I need to do is wait. I don't need to think about it getting better. I don't need to think about what's out there for help. But if I can at least, grasp on to the concept of wait. And I personally, just within the last year, have had far too many friends who have been middle-aged moms who have lost their kids in their 20s to suicide. And I've been intimately familiar with suicide, what that means for people, but somehow in the last year I just it's gotten to a place where it's like, this is not somebody with a terminal illness who's making some choices. I won't get into how I feel about that, but these are people who are, could be somewhere in and around prime chapter of their life, who aren't physically ill. So anyway, I just feel like that's a much more tangible message when it comes to suicide prevention. And I did at the state mental health conference last fall, I did sit in with a panel group and had a really good conversation about the possibility of that being more of a visual sort of message for people who have found themselves in that very, very dark place, and a place of desperation, and a place they feel they can't get out of. And, instead of trying to convince them that it can be better, that maybe they can hold on to the idea that if they wait, there might be light on the other side.
Thanks, Lynette. You made that very, very tangible and powerful. Thanks. That's interested in talking about it more.
Yeah, well said, Lynn. I feel like your words are accurate and something I can definitely relate to in process, considering peer support and also in my own life. So thank you.
Yeah, thanks for your comments. And I apologize for not making the space for public comment questions when we had time with Tom. We've talked about doing that, not as a rule like every time necessarily, but as generally an intention to try to, whenever possible, do that. And that might have been possible today, and also I think part of the reason why we don't always do that or don't always have open meetings is when sometimes our time with DMH is really small and really scarce, and we don't have time for committee members to ask all the questions that they want to ask. And so I feel like if we don't prioritize that, then there's not necessarily a need for there to be a defined committee per se. But we can definitely thank you so much for the reminder, and absolutely always want to do that whenever possible, and probably should have done that today.
Yeah.
Are there any other members of the public who want to make a comment?
I'd just like to say thanks to Lynn again for what she said, and Bert as well. I feel the same way, because I have those issues, especially the last few weeks has been a little rough for me over here. And I think that maybe with Lynn, I think that if get some kind of my mind working in a creative way, maybe your weight could be some kind of just do it type of thing. Maybe you could make a little slogan or something that might help.
I mean, am I allowed to respond?
Yeah. I mean, we probably for time need to move on soon, but go ahead.
I was just going to say, I think that any kind of message that's going out there needs to be done in a collaborative and strategic way. And I mean, I think that it's easy to throw together some graphics and say, hey, we're going to put weight buttons out there or whatever. But I think it really has to be done carefully. And but I can say that the flyer that I printed out today that came with the information, the Mental Health Awareness Month flyer, I mean, I think it's a really good example of lots of good information, but as far as a visual message that stands out format-wise, if nothing else, it's, lost in the clutter. So anyways, I don't think that, for example, this committee should be just impulsive about it, but I think that we need, it's worth consideration, and so is a way to roll it out if there is collaborative support for it.
Mm-hmm.
Mm-hmm. Absolutely.
Yeah. Thanks, Lynn and Greg, so much for your comments and contributions, and looking forward to hopefully applications for both of you. I think I would like to just bring back a couple questions that we've had for DMH in the past and see if there are any updates on answers to those. One is we'd asked for information about cash days on hand for different hospitals and designated agencies. And is that info available?
I will make the request again. I made it after the last meeting, and I do not remember where that ended up, but I will get back to you.
And we'd asked also if there were any statutory changes or updates about those that DMH could share.
And I will ask about that.
Cool. Does anyone else have any follow-up things that we asked for and haven't gotten an answer for, or any other questions? If Eva's bringing some questions back.
I feel pretty well covered. I wasn't meaning to misspeak or misrepresent the committee in thinking about ANSA. I was perhaps a little bit cynical and a little bit overly passionate, but I see the need for an assessment which is viable, and I think that incentives should always take precedence to a specific indication or directive that is handed to somebody. So anyway.
Yeah, no, I think you are free to voice any opinion you want to, and I appreciate your passion.
And it was good. I liked it that you asked the tough questions, because Allison was, made her think it through, and it was good to make her think.
I hope Allison wasn't offended. I think it's a tough question, but the work that has been done over the last couple of years seems to be very important, and I think for the most part very well done. So,
yeah.
I'm curious to hear if there's any conversations happening at DMH about racism and relationship with the DAs and designated hospitals with police, and just where those conversations are headed, what they're looking like, if they're happening.
Happy to ask and report back.
That'd be good.
And then minutes. That was the last thing we were going to do. Approving the minutes.
The last email I got from Eva was, "Are you available to talk about potential edits during this meeting today?" And yes, that is certainly my aim. My aim in creating a first draft that was more of a dictation was, I think, out of concern and uncertainty for my passion about being accountable, to the public, because we're an advocacy board, which is, providing important feedback to the DMH. And number of committee members voiced having difficulty in the last number of months. I wouldn't ever editorialize minutes in specific to someone's name. However, I did ask questions kind of along those lines. I was hoping more for clarity, even though maybe not very concise. And so I found myself overworking and perhaps underproductive, considering the time that I put into this, all told. So whatever edits need to happen, I can rectify as of tomorrow morning or late tomorrow afternoon. Not meaning to complicate this process. I'm just trying to be accountable.
I wonder if, because it sounds like there's a bit of conversation to be had here, potentially if we can actually defer this, because we did skip a break and said we'd end a bit early. For if anyone who hasn't already given you feedback could do that via email. Is that
sure
acceptable?
That works for me. I I can process any feedback received and make edits, or we can wait until discussion for next month.
Were there edits to the meetings that were to the minutes that were suggested? I saw I think those were your questions, Bert, about posed in red in the minutes.
Yes.
Yep. But other than that, were there?
Dan responded via email. Malika responded, and so did Eva. So in that sense, as of June 1st, the idea was to let things alone, send out a draft, have the discussion, and then make further edits.
Got it.
So that said, I received the emails but did not particularly process them. I did make a second draft without specific comments or edits from committee members. So yeah, that maybe doesn't answer your question succinctly.
Nope, they looked good to me.
Okay.
Okay, great. So thanks for that, Bert. And I would say if you haven't heard from anyone, then I would assume that, or from certain people, then I would assume that they're good with it. And otherwise, people will give you their feedback via email. We'll finalize them at the next meeting.
If you're willing to do this work, but with the concentration issues and the over medication that I'm experiencing right now, it's been very difficult. So.
Yeah, well, thanks for your efforts, and I think don't sweat it. It's not like we're fortunate to have Eva as a backup, so I think it's gonna be fine.
Okay.
Thanks.
Cool. Is there any other business or people good to end the meeting?
I have one comment, and it's actually from the minutes. I'll try to keep it short. It's on page 3 of the minutes. There was, it says, an SPSC member stated that over the last 6 to 8 months, they pushed for more changes than in the last 15 years. And they had goals for productivity and advising DMH, et cetera. Basically what that sounded to me like was that the committee is sort of, and again, I'm brand new to this, so I don't have the context, but it occurs to me that it would be very helpful for me, and there's these letters that have been kind of in the wings as maybe being proposed to send to DMH about how the committee should fulfill its responsibilities, et cetera. It feels to me that especially if the people here today are going to be considering joining, and that the committee will be increasing in membership, that for me personally, I'm proposing this for something for older members to think about, is that it would be helpful, I think, to maybe hear some sort of retrospective from longer standing committee members about sort of where you're at right now, what you see as your current items of particular interest, and sort of maybe what led up to the letters, kind of a where we're at check-in, kind of introduce new members to maybe the longer standing members of the committee, so that I, for instance, would know a bit more about the other members on the committee. And I'm thinking that might be helpful maybe in a couple of months, maybe when there are additional new members. Just a thought. That your perspective, having been longer term members of the committee, would be very, very helpful to me, I think.
Yeah.
In response regarding the minutes to that question, Kate, that very definitely was editorialization, but so maybe in some respect I'm a little bit guilty of editorializing. I didn't attach a name to that comment. I felt like that may have been something important specific to some of the difficulties that we've had in this last number of months. I'm not a long-standing member, so I can't do much to respond to the rest of your question.
Yeah.
It's not something that I believe is ethical unless circumstances are extenuating. So,
yeah.
Right.
It just sounds to me like there's a lot of expertise on the committee and a lot of energy and a lot of interest, and that DMH is also undertaking its various big initiatives. And it seems like sort of a just again, as a new member, it would be really helpful to sort of maybe understand a little bit more of the history and about the committee itself. I don't know. It seems like a very dynamic and kind of a committee with a lot of expertise, and so just knowing a little bit more of the history to me would be helpful.
Yeah, great idea. I know for me, when I first joined, the first time that I joined, I just felt so lost for such a long time about what we were doing and how it worked and what I was allowed to do.
Yeah.
Yeah, I hear that.
Yeah.
I don't know how much
And
I
also,
can provide, but.
And I think it also kind of ties in with these letters that are pending about how the committee should fulfill its responsibilities. Anyway, just a thought, again, for the committee to consider.
Okay.
Thank you.
Thank
Yeah,
you,
I think that's a really good idea as well. It's like, because I don't even know who's is the president, the VP, the secretary,
Well, the short answer. Go ahead, Mike. I shouldn't speak over you.
Okay. A few faces are familiar, but that's about it for me. As far as, this is only my first time anyway, but.
Well, to me, the short answer to that question, Greg, is that we're trying to share duties of secretary and chairing, which is often a president of a board on a 3-month rolling basis. So.
Okay. All right.
And that to me is a format that I think works well. I feel like we have a fairly diverse, group of people here with our own mindsets, and I think that that's maybe healthy for this committee concerning hopefully the work that we want to see in advocacy and in advising the DMH. So
absolutely, I think that's a good idea, Bert. I think that it takes the pressure off of a lot of people if you don't have to have a title, right, that you have to keep fulfilling all the time.
Sure.
Just.
I need to go. So I don't know if we want to end now or if people want to keep going, but I really have to go.
You're good. I feel like we covered everything on our agenda. Yeah. Do members of the public feel heard? I hope so.
Yeah, I think we're good. I'm good.
Yeah, I'm good. This is a very good first.
Can I motion to adjourn? Then can I motion to adjourn? Maybe.
Yep.
Sure.
Yeah.
Okay.
Sure.
Seconded.
Thank you. All in favor?
Aye.
Aye.
Great.
Okay.